Welcome to another webinar with the Olleyes family. We're very lucky tonight to have the participation, and we have a special guest. We have Dr. Davinder Grover and Dr. Fellman from Glaucoma Associates of Texas, both renowned glaucoma specialists with an extensive experience in the evaluation and treatment of patients with this disease. I'm going to briefly start tonight describing very succinctly the platform, and then I'm going to let the expert to jump in and explain more in detail, especially their experience using the VisuALL. As a recordatory visual, it's basically a virtual reality platform that intends to include as many as we can psychophysical tests in order to provide a comprehensive evaluation of patients with eye disorders. We have two main models, the VisuALL S, which is intended to be used at the office, and the VisuALL H, which is for the remote assessment of visual function, whether at home, the battlefield, everywhere, nursing homes, whenever is necessary, remote assessment of this patient. The platform is divided in three main components: the cloud, which is where everything happens, all the analytics and algorithms run there; the web app, which is the tool that the doctor is going to use to access the platform, see and the reports, prescribe the tests, and in general interact with all the visual capabilities. And the third component is the headset, which is basically the part of the system that the patient interact with, and the part that we use to stimulate and record the sensitivity of the patient. We did an initial validation at Wills Eye Hospital, which was published in the Journal of Glaucoma. We are continuing this validation, scientific validation. We're very interested in providing a science to all of you. We already submitted two other manuscripts. One is related to the technical components of the VisuALL, and the second one is the validation of our pediatric pupillometry. It was done at Vanderbilt Eye Institute, and it was sent to the American Association of Pediatric Ophthalmology. I think I'm going to leave it here. I'm going to pass the ball to the expert. Thank you very much, Dr. Grover and Dr. Fellman. And I'm going to, you're willing to, you are now capable of sharing your screen if you want.
Perfect. Okay. All right. Alberto, thank you for making this happen. Thank you for
Pleasure.
your help. And also, thank you for bringing this technology out and helping develop it, because it's very exciting, and it's an honor for me to be here with my friend and colleague Ron Fellman, and we're going to talk to you a little bit about our initial experience with the Olleyes virtual reality platform, specifically the VisuALL. These are my disclosures of pertinent. I am a consultant for Olleyes, but these are obviously our own thoughts and our own slides and our own examples. And these are Ron Fellman's disclosures. But what we want to talk about today is really first what led us to this point. I think we were really in the depths of this pandemic, looking for ways to better take care of our patients. And so we're going to talk about what set us up for this, and how we came upon Olleyes and our relationship with Alberto, and what we've been working together to try to do. Then just discuss some clinic flow using this platform, and then really get to the meat of kind of the details of VisuALL, and the most exciting part that I think that made Ron and I, very curious and interested in this technology were clinical examples that we're seeing on a daily basis. So, we can all, right now it's December, we've been battling this pandemic, at least in the United States for about 9 months. And, back in March, we didn't really know a lot about transmission and safety and how we can exist and run clinic. And we initially, we shut everything down, as a lot of people did. We had put a complete stop on perimetry, because we couldn't fathom, when we have an airborne pandemic, respiratory pandemic, having people stare into a bowl, and feeling confident that we could adequately sterilize it to keep our patients safe. And then, there were some indications and instructions on how to clean the bowl and keep it safe, that the companies that make these perimeters put out. But that really, it takes at least 15 minutes, I would say. Right, Ron, you think 15, 20 minutes to clean adequately the machines in between patients. And that, when we're in the day and age of needing to be even more efficient in our clinical practice, get our patients in and out of the healthcare system as quick as we can to minimize their risk, as well as maximize the safety of our staff. And we just didn't think this would be a realistic thing to do in patients on a regular basis like we were doing pre-COVID, unless we felt it truly was going to make a clinical difference in our decision-making process. So we initially put a complete stop to virtual field visualities, Humphrey visual fields, and then we slowly started integrating it back. But we knew, based on the clinic volume that we had, that this was not going to go. Gone are the days where a patient can stick their head in a bowl, and then 2 minutes later, another patient sticks their head in the same bowl. You're putting, an eye patch on each eye, trial lenses, all these things. And with the mask, we've seen cases where the mask the patient's wearing are inducing an artifact that can mimic glaucoma, bilateral nasal steps. So we knew what we were doing was different. And I think, that we're going to emerge from this pandemic better and stronger and smarter and more resilient, because it's these kind of situations that force us to think outside the box, force us to challenge the paradigm that we're currently in, force us to be better, and also give us the liberty to be better. And that's what I think this platform has done. And so, what do we need from a perimeter in general, even pre-COVID, but what do we need specifically post-COVID? We need something that's reliable, reproducible, and quantitative without question, efficient and safe from a patient's perspective, and from our staff's perspective. We definitely need something that's easy to sterilize. Being affordable is key. We're all being, our expenses are going up, cost of living is going up, and reimbursement continues to go down. And we need something that's comfortable and easy to use. And that's what really, I think, piqued our interest in this platform, in VisuALL. And you can see here, and I think Alberto will talk more about this, but this is the headset. This is actually a little handheld remote, and then this is the tablet that comes with it. And the technician administering the test can actually use the tablet to see exactly what the patients are seeing. And I believe, Alberto, you may get onto that a little bit more in the later on. But it's very sleek, and it's fascinating. And you saw this image right here with all the trial lenses. What's nice about this machine is that it's actually very comfortable, and patients can actually just wear their own spectacles, and then it fits over in a very comfortable way. So you're not needing to worry about trial lenses at all, and it's testing both eyes at the same time. Now, Ron is going to talk more about this. This was actually from the paper that Alberto referenced in the Journal of Glaucoma, comparing the virtual reality platform to Humphrey and some of the parameters.
Great. Thanks, Davinder. Thanks, Alberto. Talk about a technology that came about just at the right time. You really kind of summed it up, Davinder, where, wow, I'm not sure what we would be doing without this technology that came about literally just in the nick of time to save us. because as a glaucoma doctor, if you can't do perimetry and do it in a way that's meaningful, you're in big trouble. So I wanted to mention a couple of things that are really the heart of perimetry. And in a way, if you look at this table, you can see under specifications, the stimulus, we're still basically dealing with white-on-white perimetry, which most of us are familiar with in the age of static perimetry. And the duration, you see 150 milliseconds. I think that's a little bit quicker than the Humphrey, which I think is 200 milliseconds. So, but if you've taken the test, which I have, it's reasonable, makes it go a little bit quicker. And as everyone knows, fatigue is a killer in perimetry. So the faster, the better. The background luminance is 1 candela per square meter. And for those of you that are kind of Trolan, Apostille, millilambert, decalambert geeks, like the guy who taught me, John Lynn, if basically you can take a candela, multiply it times 3, and you get apostilles. So interestingly, the background luminance of this new virtual reality platform is almost exactly where the Octopus was when it started, which was 4 apostilles. So this is 3. So it's somewhere very close, similar in that range. So, you know, eventually they changed the Octopus settings. They changed background luminance, depends on many factors. But that gives you an idea. The test distance is infinite, which, as Davinder mentioned, the patient just wears their glasses, which is wonderful. Wonderful technology. You don't have to worry about putting all the lenses in and the cylinders and all that. The stimulus size is the Goldman 3, which is pretty standard on all of your static automated perimeters, which is about 0.43 degrees. You see the stimulus locations around 50. The gaze tracking is Heil-Krakow, which is basically your blind spot monitor. Machine maps out your blind spot, and the LED will light up in the blind spot at a certain point. And if they see that, you know, then they're not fixating like they should. It's touchscreen for the operator interface. There are your different fields, 24, 10 degree field, or the 30. And then Alberto mentioned the pediatric. That's really exciting. And by the way, the color vision was exciting, and the visual acuity is exciting. The threshold strategy, it's basically full threshold and fast threshold proprietary. And then the connectivity, it doesn't weigh very much, as you can see. So it's basically very similar to your concept of white-on-white perimetry. And as you can see, the background's a little bit different. The brightness of the lights are a little bit different. But those are things that those are things that are refined as we make progress with this virtual platform.
Very nice, very nice. We just got, and I appreciate the questions. You know, I didn't mention this, but I think it should go without saying that the reason we're doing this is we really want to make this as interactive as possible. We'll try to address a lot of the questions that you have. Please use the chat feature to type out any questions you have. Teresa, I appreciate you asking your first question, which was, can the patient wear progressive or bifocals during the test or reading only? Actually, they want to use their distance vision, so they can use it and just use the top part. And it doesn't take, it should not matter because they're actually focusing on infinity. And then Alberto and Ron are also well versed. So please, if I say anything that may not be truly accurate, please correct me. But that is what we were told. And so here, this is what's exciting about this technology is that it has, because of the cloud-based, technology-based interface, it can really update dramatically quickly. It's almost like the Tesla of visual field machines. Really, you know, it's a month ago we didn't have the 30-2, I believe, or 2 months ago we didn't have the 30-2, and now we have the 30-2. And so these are examples of the 30-2, 24-2, and 10-2. And so, you know, it's just rapidly improved. It's already at an amazing point, but they're continuing to really provide great real-time improvements to this technology that make our day-to-day lives so much easier, as Ron has mentioned. But this is the printout that you'll see, and it's quite similar to the Humphrey visual field printout. So it's not a big mental change as far as if you're used to looking at Humphrey visual field printouts. And then, as Ron mentioned, what's exciting is that, again, these are things that are easily added to color vision, visual acuity, and the pediatric component, all of which are just dramatically flexible and rapidly updatable and rapidly evolving. So for only improvements, it's already amazing, and it's only getting better, actually. So, when we think about the pros and cons versus the, what's it like using this VisuALL system versus the Humphrey visual field system? This is an efficient cloud-based platform. It's safe. There's really no patch needed. You're actually testing both eyes at the same time. It's comfortable. It's reliable. You have those patients that are leaning into the bowl. They have neck issues, or in their wheelchair or other things, or they just, they have a hard time sitting up there, and the patients can put it on and sit in any position they want. You can really, because it's a self-sustaining platform, the patients don't need as much monitoring as a Humphrey visual field machine would. And so the technician can, get one patient set up, monitor that tablet, and then get another patient set up, monitor that tablet, and be able to do more than one at a time. So it can improve efficiency in the OR. It's definitely easy to sterilize, much easier than the Humphrey machine. As I mentioned, as we're seeing in the examples we already gave, it's constantly updating. You don't really need a lot of space. You don't need a dark room and an entirely different room. Our initial clinic, we had a whole room for each Humphrey field with its own computer, with everything. And here, the patients can kind of sit in the position they want at the location where you find it best. And then there's this potential again for home monitoring or outside the office monitoring, which I think a lot of things are moving towards, given the challenges the pandemic has placed on us. What are the things that are some of the cons, or things that are less desirable right now about the VisuALL? We're still, the initial data that was published was on normals and mild glaucoma, so there's still not a lot of data available on advanced glaucoma. But that's what's expected with this new technology, and that's the data is being analyzed and rapidly being generated, and we will continue to work to evaluate this in a scientific, evidence-based manner to continue to show validity. The size 5 is under development. The progression analysis is something that, again, is going to take time to develop. There are some patients, and it's typically some of the older patients, I would say patients in their 80s, that are just not used to having a virtual reality machine and the interface. But the younger patients, the kids, people in their 20s, 30s, 40s, 50s, 60s, and even 70s, they love it. And a lot of the patients have provided us really good feedback. I mean, it's still a visual field, right? So when I ask my patients and I'm talking to them and saying, you did the Humphrey test, and then you've done this one, which one do you prefer? They're like, oh, we don't like any test. I was like, okay, well, if you had to choose, what would you choose? And a lot of them are really happy with this technology and this interface. And so what it's allowed us to do in clinic is it's really allowed us to shunt away a lot of the patients that perhaps don't necessarily need the benefit of the established progression analysis yet. And the normal eyes or the mild eyes, or the patients that are in wheelchairs. And if a patient tries it, they say they love it, I have them getting the VisuALL from now on. If patients try it and they have a hard time with it, that's what we see even with the traditional visual field machines. The first time someone takes it, they don't like it, and they get used to it. So I tell them it's a learning curve. But if they don't like it and they can't tolerate it, then we consider a different platform. That's pretty rare. The global indices available there, but you need some statistical significance right now on some of the indices that they're printing out, and that'll come with more data and more evaluation. So we've kind of talked about the nitty gritty and some of the patient flow, but let's. This is what really kind of really surprised me in a good way when we first started playing with this technology. And I'm going to show a couple of examples of patients where there was a normal visual field and they had a normal visual outcome. An abnormal visual field showed a similar abnormality on the visual. And then there are some patients, and this is really powerful, where the Humphrey was calling it a quote unquote normal field, but the visual picked up something that we think is real. So here's the first example of that, what I just said. So it's a 72-year-old female of European descent. I've been following as a glaucoma suspect for several years. Her IOPs have been in the mid-teens. No family history. She's pseudophakic. Vision's great. Her pressures have been in the mid-teens. Slightly thicker than average corneas. And her corneal hysteresis is 9.5 and 9.9. So average, if not a little bit below average, which can perhaps put her at a slight increased risk of glaucoma development and progression. These are optic nerves. You can see on the right side, pretty suspicious and concerning for a glaucomatous optic neuropathy. She has that parapapillary atrophy, and that, without question, is in anyone's mind suspicious for glaucoma. And this is actually, I saw her in the before the pandemic, in the late 2019s, and she was having some decent. You can see, I'm not sure if it comes through the fixation losses, but 9 out of 14 on the left eye and 5 out of 14 on the right. Not the most reliable field, but I would say in general, when I read this, I said, look, it's unreliable, some fixation losses, but it's actually pretty. I would call this a pretty normal field. That's not concerning to me. And then if you look at her OCT, on the top is the left and the bottom is the right. The third test, number 3, on May 29th, that's obviously the post-pandemic. And we didn't really get the best quality, whether it's the dilation or the masks or whatever. Our signal strength was a little down. But if you look from 2017 to 2019, I would say, there may have been a little bit of change in the left eye, but I wouldn't call that a real progression on the left side. And even the signal strength of 7 out of 10 with the possible thinning, I would want to see something more before I would ever call that progression on OCT on the left eye. But if you look at the right, from 2017 to 2019, this is pre-pandemic, right? This is back when we were living a different normal life. You see the inferior quadrant nerve fiber layer has went down almost by 15% or so, from 103 to 87, and even the superior quadrant went down, and that's real. And then the one from May, again, the signal strength is down. I wouldn't call that change or progression, but I would say that from 2017, 2019, I would call that highly, highly suspicious for possible worsening. Now you look at her visual field that we did in September of this year. She had fewer fixation losses, right? Much more reliable, and the left visual field is normal. But if you look at the right, total deviation, the grayscale shows possibly some decreased contrast sensitivity up top, but you look at the total deviation, even the pattern deviation, you see a defect that is very classic for the nerve fiber layer loss. And what was interesting is that the traditional Humphrey didn't pick it up. So perhaps what's challenging me with this technology is it's picking up classic field defects that correspond to nerve fiber layer perhaps sooner than we would see with traditional Humphrey perimetry. And this example, I think, was one of the first ones that and we've seen a couple of them like this, that just, blow you away and make you reevaluate the OCT, make you reevaluate the patient and say, wow, this patient is not just a suspect, this is a real deal. And this is the earliest sign of parametric glaucoma. Humphrey Visual Field is calling this pre-parametric. The VisuALL system is calling this parametric glaucoma. I was able to get a more reliable visual field showing a defect corresponding to the loss on OCT, initiated latanoprost and reset her target down to the low teens. And that was a big shocker to me when I saw the results of that. Here's another patient that had a normal visual field, an abnormal visual, but I would not call her progressive. I've been following her. She's young. She has low tension glaucoma, and she's stable on latanoprost and Bunod, and pressures in low teens, thin corneas, very low hysteresis, which is again puts you at a high risk of glaucoma progression and development. No family history. Thankfully, your blood pressures have been really reasonable. And you see on the left side of the screen from 2018 November, and on the right from November of 2020. So 2 years difference, 2 years and 5 days. You could possibly say that, you know, you see the 81 average thickness on the left in 2018 and goes to 78. I think that I'm going to chalk that off to just normal test variability. I don't think that's a significant change. But you can see on the right eye from 2019 to 2020, a very classic glaucomatous optic neuropathy. Actually, in 2019, you can see a small disc heme at around 7 o'clock, right down here. And on the left, you still see a glaucomatous optic neuropathy, but thankfully not really different over the past year. This is her visual field machine from visual field testing in the right eye, March of 2019, to recently in the right eye with the VisuALL platform in the past couple months. And what's interesting is, again, if you look back at the right eye, that's classic glaucomatous optic neuropathy. You see loss of the inferior nerve fiber layer. You see a hemorrhage on on a disc hemorrhage, and you can see loss in the inferior temporal quadrant. And then you'd expect to obviously see a superior defect. Now, again, this is a more reliable Humphrey visual field on the left side of the screen. The total deviation shows a defect pretty diffusely, but the pattern deviation doesn't really pick up anything, and it's really just a general reduction of sensitivity. But what's interesting is when you look at the right eye on the VisuALL, that defect is more clear, more consistent with what we're seeing, and I would say is more reflective of the patient's disease. And you see that a little bit on the grayscale. You see it on the total deviation. You definitely see it on the pattern deviation. And then the same thing is true in the left eye. So we look back at the left eye, again, classic glaucomatous optic neuropathy. Left eye on the Humphrey is showing a general reduction of sensitivity, not really detailing out a specific defect. But when you look at the total deviation and specifically the grayscale and the pattern deviation, you're seeing a defect more consistent with the patient's exam. And then here's some just examples of, you know, if you have a patient that's normal, suspect, ocular hypertensive, whatnot, you've been following them with Humphrey for, you know, I've been following this patient from 2016, annual Humphrey fields. We do a VisuALL system and it's normal. I have no doubt at all that I can continue to follow this patient with the VisuALL system and don't need to expose them to having a Humphrey test. And that's true in the left eye as well. So when we're seeing normal, we're seeing normal in a normal eye. Here's a patient with a pretty significant inferior defect, stable, thankfully, from 2016. On the left side, you're seeing the Humphrey output, and you see that inferior arcuate defect, and it translates pretty similarly to the VisuALL platform, mapping out a very similar pattern of a defect. So again, because I have a long history of stability with this patient, I've been following them since 2016. I have a very reproducible defect in the VisuALL system. This is someone else, even though they have more advanced glaucoma than the Journal of Glaucoma paper put out and was studied. I feel very confident continuing to follow this patient using the virtual reality platform and not having them exposed to a Humphrey visual field test. And here's some cases from Ron. I'll drive, but go ahead and take over, Ron.
Sure. You know, it really is advantageous for us to have seen a patient for 10, 20, even 30 years, know them really well, and then get to look at a new technology with regards to perimetry, because we really understand some of our patients very well. So we know what correlates and what doesn't. So we're continuing to learn, but here's an example of a patient that I've been seeing for several years. They're now 67. They're on, you can see these medications, dorzolamide timolol combination twice a day, and they're on a prostaglandin at night. And their initial pressures were, I think, somewhere in the mid, maybe 26, 27 range OU. And they're pretty good at 18. And their glaucoma lately has been stable. but you can see there's a significant nerve fiber layer dropout inferiorly that's picked up on the OCT in the right eye, and not quite as significant in the left, but definitely you can see dropout. And if you go to the next slide, you can see, I think, the optic nerve. So the right nerve, you can see, that disc is pretty suspicious for damage because there's thinning inferiorly. And in the left eye, the rim certainly looks better. So you can tell your antenna go up more so in the right eye. So that's what the nerve looks like. So let's look at the next slide. Okay, so you can see the Humphrey field shows a pretty classic superior nasal step that's definitely reproducible, and that fits the optic nerve. And you have to remember, it doesn't always fit in a classic way, but it fits pretty well here. So let's take a look. As I'm learning about the new virtual reality platform, I'm looking, as you can see, right below the rectangle under false positives. I'm looking at false positives, and this one's a little higher than I usually see in most patients, but I want you to pay attention to it. And then I go and look in the fixation losses, and it's 1 out of 4 here. So this is a similar Heil-Krakow method where the blind spot is mapped out, and then the light is shown in that blind spot, and it was only seen 1 out of 4 times. That's probably pretty good. Now, if you look at the grayscale, it's not overly impressive at just looking at that. But if you look at the total deviation and you look at the black boxes, you can see a correlation. And we're learning, how well do these things correlate? Do they correlate better in mild glaucoma? Is it better in moderate? What about advanced? We're still learning these things. But you can see the PSD, the pattern standard deviation, right there. It's 3.78. So there's a definite, pattern localized type defect. And when you see 1, 2, 3, 6 black boxes that take on that configuration, and you're looking at the virtual platform, we learned that is significant. And especially, again, I stress always looking at the reliability indices. So it was good to see that was picking that up. Now let's go to the next one. Now here's the left eye. So the left eye, interestingly, is pretty normal. If you look at it, that's a normal Humphrey field, and for the left eye, reproducible. And if you look at the virtual platform, again, the false positive, a little high, but the fixation loss is good, mapped out the blind spot well. And, there are a few areas there of black boxes, and I'm looking at some of those numbers, and you look at the decibel level. And remember, a decibel of 30 decibels on your virtual reality machine is not the same as 30 decibels on a Humphrey, and not the same as 30 decibels on an octopus. It's a relative logarithmic scale decibel. So don't get hung up on that. But clearly, the left eye picked up a few things. And if you go back to Davinder and look at the OCT of the left eye, it was abnormal. So we all know that the OCT in early disease is probably better at picking up an abnormality than the field as far as white-on-white perimetry. But, the virtual platform, the background in the background is a lot less. So maybe we'll learn that's better for picking up certain things, certain scotomas. We don't know yet. We're going to learn that. Now, that's the nature of perimetry. But it is picking up something, and you can see the pattern standard defect's a little abnormal. And so I talked to this patient. I said, how did you like the virtual experience? And she liked it. It was easy, and especially she commented, I didn't have to worry about putting on a patch, which I was worried some patient, before may have had a problem. And I think, what is it? It might be like 3%, I think, or 2%, Davinder, of COVID cases will have the virus in the tears if they have conjunctivitis. It's some number. So
Yeah,
it's not,
actually, it's
it's
pretty
there.
low. It's actually less than maybe 1%, 1%,
1%.
2%, depending if you look at the studies
Whoa.
that are out of Singapore or out of China. But it's pretty low, and um, in most patients that were admitted in Singapore and even out of Wuhan, the initial hospitals that were PCR positive in the hospital with COVID, they had a very hard time isolating
Virus.
viral particles from the tear film, and there's been very little evidence they've actually been able to culture the virus from the tear
Good.
film. But
That's good.
it's still a theoretical
Yeah.
risk that we need to be aware of.
Exactly. And the fact that a patient breathes into a big bowl during a Humphrey for 10 minutes, and then a patient, and then another patient comes in and breathes into it. I don't care how much you sterilize it, it freaks some patients out. And they don't have that problem with this. And amazingly, most of the masks don't bother the virtual fit. That's because I was talking to our technician about that. That's a rare problem, and that was certainly good news.
Yeah.
And I wanted to just show you this where, maybe this is picking up something, as we repeat the fields and learn more, we'll be able to increase our knowledge base. Okay, so our next one is, we can go to the next one. So this next case, it's a 75-year-old patient with primary open-angle glaucoma. They're on a prostaglandin at night. Their pressure runs around 16. It used to be 22, and they underwent phacotrabeculometry, which helped their pressure pretty significantly. As you know, that increases the trabeculum, helps increase the outflow through their natural channels. But this patient's been a long-term patient, and if you look at the nerve fiber layer loss in the right eye, there's a significant area there that's for real. And not so much in the left, maybe a little bit in the left eye in inferior area. But certainly, you can look at that OCT, and it's pretty impressive as far as the right eye with loss superiorly. And that also shows up, interestingly, in the ganglion cell, which you can see on the right side. And you can also see there's significant ganglion cell loss in the retina in areas that correspond to the nerve fiber distribution. So it actually occasionally makes sense in glaucoma, but not always, that's for sure. So that's what the nerve fiber looks like. So let's go to the next slide. So we have here, you can see the virtual platform. The false positive rate here is really outstanding, 0. This is a well-trained perimetry subject. And no fixation losses. Now, this, if you advance it, I think it will show up there's the Humphrey. So this patient has a corresponding inferior nasal step loss that corresponds to the nerve fiber layer superiorly. That makes sense. This is a reproducible defect. And it shows up quite nicely on the virtual platform. And this is a 24-degree field, correct, Alberto? Correct. So the thing I like about it is nasally, it tests an extra spot on the nasal meridian. It tests 5 locations that you see, and it goes out to that 5th one, which is a critical area because you can see in this particular patient, it picked up a loss. And you can see also shows up on total deviation, also on the pattern deviation. And the pattern standard deviation is pretty significant. I think it's 5.64. And the mean deviation is minus. So these are all significant findings in the right eye. And it's very nice when you follow the patient for a couple of decades, you know what you expect to see, and you actually see it with new technology. That really is exciting to see because we really need new ways to do the field that are better. And I think I may be wrong with this, Alberto can correct me, but it says on this, you can see the time, it's 5 minutes, 31 seconds. And I think that's for both eyes. Is
So
that correct?
that is actually each eye, which is in correlation with, it's a little bit shorter than the,
Oh, okay, so that's per eye.
yeah.
Okay, because let's see the fellow eye, Davinder.
You know, just another good example of this is the reliability indices on the VisuALL field compared to the reliability indices of the Humphrey are pretty significantly different here, which we're seeing more. I mean, when people like that interface, I think it's we're seeing that more.
No, that's a good point.
We believe that that might be related to the isolation from the, so when you are on a Humphrey or any other ball perimeter, you are still in a real world, and it's very easy to be distracted by anything. When you are on the virtual reality platform, it creates some sort of like isolation from the rest, and there is nothing virtually to look at within that headset other than the fixation point. And as you know, physiologically speaking, it's very difficult not to follow the fixation. That's what we believe is related to it.
Right. And you know what else I'd like to see, which is good, is I always look as well, you know, as we mentioned before, the false positive rate. And as you know, if I'm correct, if the stimulus is shown for 150 milliseconds, if the patient is responding and pushing the button outside of that window, you know, then that's, in other words, if there's no light presented and the patient's pushing the button, it's a false positive. And the false negative, you have to remember, once the machine reaches threshold, and let's say it's 30 decibels, it will go back and present a much brighter light, 10 times brighter at 20 decibels. And if they don't see that, that's a false positive, that's a false negative. Am I correct on that, Alberto?
That is correct. The only thing that we're doing different a little bit is that, so when we looked into the reliability of visual field, we found very strong evidence that false negative doesn't affect the reliability of the visual field like the false positive.
Okay.
So we're putting more emphasis on the false positive in terms of the detection of it, rather than the false negative.
Okay, well, that's good. That's good to hear, because, you know, we all know if the false positives are high and the patient's button happy, you know, you can miss scotoma big time. And the false negative is less understood what that really means. So I'm glad to hear that. But again, those are all the things that we look at and are available to look at, and you should be looking at. Okay, I think we have maybe one more here. So here's another case of a 73-year-old patient, has primary open-angle glaucoma, is on brimonidine in the left eye twice a day, and takes a prostaglandin in both eyes at night. And I've been seeing this patient for several years. And there's the right nerve, and you can see the left nerve. And I think the left nerve eventually got a little bit worse on me. And you can see, if you advance it one, Davinder, right there is a little tiny, it's hard to see, especially with my old eyes, a little disc hemorrhage. And, you know, a disc hemorrhage we worry about in glaucoma. It's always a sign that it may have worsening of the glaucoma. Could be due to something else. You have to be a detective, you know, like you should be when you see a disc hemorrhage. And that's probably when I saw that, is when I added the brimonidine. And I went back and looked on the chart, and sure enough, I was lucky enough to see that, yeah, that day we wrote down disc hemorrhage. So I was excited to see we're on the ball that day, because, you know, it's small and you can miss these. But that's important to notice. So let's go to the OCT. So you can see, interestingly, in the left eye, there's some nerve fiber layer dropout, even at that area where that disc hemorrhage is, on the nerve fiber, right? You know, it's 7 o'clock. And then, there's some kind of diffuse loss superiorly as well. And it corresponds pretty well again, to the ganglion cell dropout. And the right nerve looks pretty good. So let's go and look at the fields. So we've got the Humphrey on your left, and you can see the right eye looks pretty good. Some fluctuation, but I'm pretty happy with that. And if I look at the right eye and look at the false positives, 2%, fixation losses, a little high, but not bad, false negative 0, mapped out the blind spot well. If I look at the decibels, I'm pretty happy with what I see there. I mean, I don't really see anything that worries me there. Mean deviation, nothing, not much on the PSD. But let's look at the left eye. So there's a stable defect in the left eye, kind of a supranasal step, a little bit of compression in the nasal, a little depression of the nasal quadrant as well, and picked up beautifully with the virtual reality platform. The false positives, again, were 0, false negative 0, 2 out of 4 on the fixation losses, but the total deviation picked it up quite well, and the pattern deviation was really exciting to see that. Very correlates pretty well to the Humphrey. And you can see the pattern standard deviation, there's 7, and the mean deviation's almost -3. So excellent correlation. This is something that we've done a ton of these already, because with the pandemic, this is a great way to look at the field. And patients are very accepting, and they commonly tell us, I'm really excited with the new technology, because everybody's still worried about the virus and the pandemic, rightfully so. So this is definitely a technology that we're seeing. This type of correlation is very common, very reassuring. And I think, the indices, like I said, so when I look at these now, I've learned I don't always look so much at the grayscale to start with. If that jumps out at me, fine. I'm always looking at the black boxes, because that's a significant defect. You always have to look at that. And then you put the reliability indices together, and it gives you a pretty good picture of what is really happening. So what's our kind of conclusion? Again, this is exciting new technology for us. I mean, I remember in 1982, when I did my fellowship, we had an octopus machine. It was the first one in the country, 1982, and it was static automated perimetry. Everything was Goldman before that. And with this newer technology, the virtual reality platform, I think is the next really big leap, away from the standard white-on-white projection perimeters. This is very exciting. And it's very exciting to have my own patients that I can look at, that I've known forever, and see the correlation. And that's really fantastic. Now, the research will continue into reproducibility. It'll be interesting to know what's the frequency of seeing curve really look like with some of these people. Maybe that research can be done. We need to continue to compare it to standard white-on-white perimetry that we know really well. And we need to expand the database, including all levels of glaucomatous damage. And we certainly are doing that. And in fact, in many of the patients with advanced glaucoma that I've seen, the correlation looks very good as well, but that certainly needs to be studied well. Now, the portability factor is what really gets me going, gives me a little tachycardia, which is great at my age. So home use, other health-related venues, wow, this opens up the whole field of perimetry. You can go into CVS and check your blood pressure. It'd be great. You go and check your field. Why not? Why not? Why not expand the horizon with perimetry? And the progression analysis, as we said earlier, it's ongoing. The beauty of this is it's cloud-based. So everything can be updated in a fashion that's very easy. And I'll tell you, I talked to my technician who does the fields. I went over and did one a couple of days ago, and just to do the test again. It's always good to know what our patients go through. And it was amazingly efficient. It was fast. I could just wear my glasses. Sometimes they'll put a little defogging solution on the lenses. I think sometimes they do that, and I think that helps. The technician, they learn all the little tricks with standard, perimetry in the bowl, and they learn the little tricks associated with this. And they can see it, and they teach the patient how to do it. It's quick, it's easy, and hopefully the patients will be able to do some of their testing at home, and we'll be able to look at it and monitor a physiologic function of the body just like the cardiologists do. So this is all very exciting to us. So we look forward to continuing to expand the database and learn about it, because, our practice, luckily, way back in the day with John Lynn, he taught me a lot about perimetry. He was really one of the founders of static automated perimetry as far as automating it. He taught a lot of that to me, and I'm trying to pass that on to my apostille buddies at Glaucoma Associates, and you can see them all here. So, Davinder and I always, we all lean on each other all the time because glaucoma is pretty tough. And, and none of us have any big egos, because if you have a big ego, it gets cut away pretty quick in glaucoma. So we all lean on each other and learn about it. But perimetry is very exciting. We talk about it all the time. We learn, we show patients things, and we look forward to continuing the frontier of perimetry.
Thank you.